Hi there. Welcome to the Health Analytic Insights podcast. This podcast is all about creating a community of like-minded individuals who are passionate about the field of health informatics. I hope to share information and advice in topics such as health analytics, digital health, biomedical engineering, and data visualization in healthcare. And in exchange, I would love to hear from you, dear listener, about your experience and interest in this field. You can drop me a line at healthanaliticinsights@gmail.com, and this email, along with any references discussed during this podcast, will be listed in the show notes below. If this resonates with you, don't forget to follow and subscribe to this podcast, as I'll be releasing new episodes bi-weekly. Without further ado, let's get into it. So I recently listened to an interesting podcast episode of Today Explained by Vox, all about vaccine distribution. So how the vaccines will be distributed will obviously vary widely from country to country. In Canada, the rollout plan that was announced will obviously change as the year progresses and things shift. However, the primary focus across Canada, at least what has been recently reported, will be that the vaccine distribution will be focused on high-risk populations, such as long-term healthcare workers, adults in Indigenous populations, and long-term care residents. So the vaccine represents a light at the tunnel for these past dark months and shows a testament of scientific research and discovery as these vaccines were developed in record-breaking time. The ability for richer nations to quickly obtain large quantities of vaccines for their citizens has given me pause to reflect on what a privilege it is to live in Canada, whereas other nations will have difficulty obtaining the vaccine and disseminating the vaccine to their citizens. Some reports show that poor nations might not have access to fully vaccinate their citizens until 2024. And this got me thinking about the topic of health equity and how it presents in the field of health informatics. So first off, what is health equity? The World Health Organization defines health equity as the absence of unfair and avoidable or remediable differences in health among population groups defined socially, economically, demographically, or geographically. Obviously, health equity is a complex challenge to tackle within the healthcare field. But the question I present to you listeners is, do you think that technology will help to bridge this gap, or will it further divide? So I wanted to talk about 3 areas where health equity might show up. And the first one is telemedicine and health equity. So we've seen countless examples of the widespread adoption of telemedicine during the pandemic. I myself had several virtual doctor's visits throughout 2020, and it's been an overall positive experience for me. Instead of waiting in the waiting room for 30 minutes and then having my appointment for 10 minutes, I was able to shave off a lot of that time. And for those who don't have access to cars or who cannot take off time off work for extended periods, telemedicine might be a more efficient method for them. It also might be a great alternative for those who are in rural or remote areas and who are low risk. However, telemedicine cannot be the be-end and be-all solution. People do not have secure access to phones, desktops, and laptops. And in addition, some groups don't have the technological literacy to access these applications effectively. And care should really be made when designing these software applications to ensure that the user interface is as straightforward as possible when it comes to accessing telemedicine platforms. So phasing out in-person visits is just not a viable option, especially when you have older, higher risk populations who can have difficulty hearing or seeing the doctor through a screen. But having that option for virtual appointments for low-risk groups might be a method to free up the doctor's time so they can focus more on these high-risk groups. And as 5G technology develops and we move towards a more connected world, libraries might consider offering more digital literacy programs focused on telemedicine to keep up with the changing times and allow people to have free resources to really understand telemedicine and reduce barriers to healthcare. So another area when it comes to health equity are appointment no-shows. So as I said before, people might not have access to vehicles or reliable transportation, And this can show up as a barrier for people when it comes to showing up for their medical appointments. And this can result in worsening existing health conditions for patients. In the past few years, there have been a push from ride-sharing companies like Uber and Lyft to disrupt the healthcare industry by providing ride-sharing services to patients by connecting directly to the electronic health record using platforms such as Cerner and Allscripts. So the purpose is to allow caregivers to schedule free or affordable rides for patients who don't have access to transportation to travel to and from medical appointments. And the purpose is hopefully to reduce the number of missed appointments. However, early research has shown that the integration of these ride-sharing companies has not made a significant decrease in the number of no-show appointments. Dr. Krizda, who led the study of connecting these ride-sharing companies to the electronic health record, stated, "We were surprised that the effect was no different between groups. We think this is likely because we didn't have a high percent of people who agreed to use the service or ultimately used it after agreeing. We think this may be the result of the way we delivered the service or lack of familiarity." A criticism of the study was provided by Lisa Sharp, a researcher at the University of Illinois in Chicago. And she stated that the study didn't assess patients' previous experience with the ride-sharing services or their perceptions about it. And it's possible they worried about drivers refusing to come to minority or low-income neighborhoods. So having a strong understanding of the health equity barriers that people are facing is critical when it comes to rolling out these tools. Although we have the systems in place, it's important to ensure that they will actually be used. And this is a common thread I see working in the business intelligence space, in healthcare. This notion that if we build it, they will come. Instead, it's important to anticipate and understand who your audience is. Have conversations with them. Understand the problems they currently are having and what training you might need to implement before building your tool to ensure that it will have a lasting impact and will actually be used. And the last place I want to investigate is machine learning algorithms and health equity. When it comes to building algorithms, which are used in the healthcare field, it is critical that the data that is fed into these models is analyzed, understood, and biases are uncovered before developing programs that can have real-world implications on marginalized groups. A paper published in Science identified a widely used healthcare algorithm. It's estimated that the algorithm was used on over 70 million patients. And this algorithm increasingly identified white patients over Black patients with respect to patients who need follow-up care, even if the Black patients were just as sick as the white patients. This is because the algorithm focused on cost over health inequities that Black and minority populations face. So Black populations across America generally tend to have lower incomes than white populations, and because the algorithm was focused on costs, and people who have lower incomes are less likely to have insurance, or they might be more likely to miss appointments, which are the issues that I discussed previously, this all may result in overall smaller healthcare costs. And because the algorithm was just focused solely on costs, the algorithm identified only 18% of Black patients versus 82% of white patients for follow-up care. However, when you focus on how sick someone is, the number jumps from 18% to 46% when it comes to referring Black patients for follow-up care. So the issue in the algorithm was only identified when doctors themselves dig more into the data and started to uncover these biases. So racial biases when building algorithms are widely documented and can continue to negatively affect our healthcare populations if we don't understand the parameters and data we are feeding into the algorithms and ensuring that we're not bringing in our own biases and lack of understanding of the populations being served. And more recently, Stanford Medicine was caught in hot water when its algorithm prioritized administration and staff who are working from home to receive the COVID-19 vaccination over frontline healthcare workers. So initially their response was to blame the algorithm, but we need to move away from thinking that AI is some external robot that's going to take over the world and understand that it's simply a mathematical tool that requires human understanding, analysis, and empathy to make better decisions. So the algorithm in question from Stanford Medicine was rule-based and might have looked at factors such as age, job, title, to factor in every risk of COVID-19. And depending on the weight attributed to these factors, especially if there is a higher weight attributed to age, then administrative staff and more established doctors who are working from home might be picked versus younger residents who are working in the hospital on a day-to-day basis. So one lesson that can come out of this is the importance of constant iteration and tuning of these healthcare models. We can't just blindly rely on the output of the algorithm and then just deploy it out there. We need to take a step back and question, how will this model affect populations, groups, and have I really uncovered all the potential biases in my data? So that's all for today, folks. I hope this discussion was of interest to you when it comes to analyzing healthcare data, building healthcare systems, or designing algorithms. It's always important to have the principles of health equity in the back of your mind. The healthcare system is rapidly evolving as we see these big tech companies like Amazon, Google, Microsoft disrupting the field, and we should be cognizant of the systems we are designing and how they will affect patients. I'd love to hear from you. How does health equity make its way into your job in health informatics? You can drop me a line at healthanalyticinsights@gmail.com, and I'll be leaving some additional resources in the show notes description. Have a wonderful day.